the role of MRI in the diagnosis of prostate cancer. So just a brief introduction. MR basically is a non-invasive imaging technique that uses interaction between the radio frequency pulses and a strong magnetic field and the body tissue to obtain images in a different plane. And we have now now multi-parametric MR is the standard recommended technique for diagnosing and staging. With staging, I mean local staging of the prostate cancer. And I will be subsequently explaining you what is multi-parametric MR in my discussion. So these are the major indications for doing MR for the prostate. It is basically for the detection and localization of primary prostatic cancer. And sometimes it can also help in MR-guided biopsies, but predominantly the technique for biopsy, as Dr. Nadeem said, is transrectal and transperineal. And local staging is very much accurate and helpful whenever MRI is used for local staging of the clinically significant prostate cancer. It can also help in identifying whenever there is a suspicion for recurrence. We can do active surveillance, and it also helps a lot in deciding local treatments like radiation therapy, focal therapy, or surgery. So what is multi-parametric MR? Basically, it includes some additional sequences, which are not just anatomical sequences. They can be labeled as functional MR sequences. And the sequences that are included in multi-parametric MR are high definition or high resolution T2 weighted images, which usually tells us better details about the prostate anatomy. And the functional sequences include diffusion weighted sequences, which display cell density, and the dynamic contrast enhanced sequences, which can better tell us about the vascularity of the lesion whenever we are seeing one. So what info does the multi-parametric provides? Multi-parametric MR provides the information on not just the tissue anatomy, but also the tissue characteristics such as the volume, cellularity, and the vascularity. So to begin with, initial sequence is the T2 weighted images in which we see the anatomical morphological features of the prostate and any morphological pathological structures that can be identified on the T2 weighted sequences. So the lesions on T2 can be localized, and their shape can well be decided whether they are round, they are irregular, they are focal, or sometimes they can be wedge-shaped, linear. So this shape characterization can better be done on T2 weighted sequences. And a focal, round, or irregular structures on T2 weighted images is very suspicious to be taken as a clinically significant prostatic cancer lesion. So in transitional zone, the cancers are usually ill-defined. Their margins are very wavy and not smooth. And they can be focal and have intermediate to low signals in intensities. On T2 weighted sequences, they are not circumscribed, can be like a lenticular or fusiform, and usually we see the invasion of the surrounding structures. And for transitional zone, it is recommended to combine T2 with the two functional sequences that are the diffusion-weighted images and the dynamic contrast enhanced to characterize the lesion best. For peripheral region, the primary evaluation or the initial evaluation has to be done on the diffusion weighted sequences, followed by contrast if needed for the decision, as I will explain you when we will discuss the PIRATs. So diffusion weighted imaging is the most important functional imaging technique because it corresponds very well to the histopathologic findings. And the DWI sequence, the velocity or the diffusion of the intracellular water is shown well. In dense cellular tissue, the velocity is reduced and therefore the diffusion is termed as restricted. This is visible as a low signal or a black signal on the DWI-derived velocity map and the apparent diffusion coefficient map, which is commonly referred to as ADC map. And dynamic contrast enhanced images are basically T1 weighted images after the administration of contrast, which shows the enhancement pattern after the bolus of the contrast injection. Owing to the tumor angiogenesis, the higher vessel permeability, and both the low-grade and clinically significant prostate cancer and cellular BPH and inflammation, they will show early and more pronounced enhancement compared with other prostatic tissue. But sometimes only the dynamic contrast enhanced images, if viewed in isolation, will be little challenging for the purpose of differentiating whether this is a malignant type of lesion or a benign lesion. Therefore, it is always important to complement the functional images with the dynamic contrast enhanced MR sequences. So MR interpretation is made slightly structured and easy by the Prostate Cancer Steering Committee, which is which includes the American College of Radiology, the European Society for Uroradiology, and the Admetech Foundation. Their joint effort has developed a standardized system, which is called PIRADS, or Prostate Imaging Reporting and Data System. PIRAD is a risk assessment tool, basically, based on the standardized evaluation to predict the likelihood that a clinically significant prostate cancer is present on the MR images or not. So at each lesion that is detected on the MR is scored separately using the description based on the findings on T2 weighted images, on diffusion weighted images, and on dynamic contrast. And after that, we combine the score and allot a PIRAD category score starting from PIRAD category 1, which is taken as benign or highly unlikely code of malignancy, to category 5, which is very highly likely to be a malignant lesion. So in current practice, PIRAD version 2.1 is in clinical practice, and they change after 5 to 7 years. They update, and sometimes the update or the recommendations, they can be, if there is a significant finding, the update is the steering committee updates the recommendations. So it emphasizes the PIRAD, basically this version emphasizes the dominant role of diffusion weighted sequences, as this parameter is very significant in identifying suspicious significant lesion in the peripheral zone, and the combination of T2 and diffusion weighted images is considered very sensitive for the interpretation of transitional zone lesions. The the images on the top slide basically are from the MRI scan. You can see this is the axial scan of the MRI. You can see this black line is the capsule of the prostate. This is some part of the rectum. And if you see this, this nicely seen hyper-intense or white area is the peripheral zone, and this low or darker area is the transitional zone, which is showing some changes of benign prostatic hyperplasia. And if you see, this is the diagrammatic representation showing you the peripheral zone. This is the prostatic urethra transitional zone. And this part, which is the most anterior part, is the anterior fibromuscular stroma. That is the sagittal section showing you urinary bladder. That is the base of the prostate, the mid part, and the apex in sagittal section. So pyrette for peripheral region, as I have said, we mostly rely on the diffusion weighted. If we do not see any abnormality, we give a score of 1, and usually if we have score of 1, it is categorized as pyrette category 1 for even pyrette category 2 are also unlikely of having malignancy, while pyrette category 3 are equivocal lesion on routine sequence. And then if we see this, we then follow the contrast enhanced sequences to either downgrade or upgrade the lesion to category 4 or 2. If there is enhancement in lesion that are categorized as 3, we categorize in the presence of enhancement as well to be a category 4 lesion, which is very suspicious to be taken as a malignant lesion. And when there is no enhancement, then it is equivocal, or it can be less likely of having malignancy. So this is the top image showing you the diagrammatic representation, how a lesion, focal lesion appears on T2. And on the diffusion weighted, it will be bright, and on ADC, it will be showing low signal intensity. And this is the lesion in the peripheral zone, and subsequently, if the lesion is more than 1.5 centimeter, the only difference between category 4 and category 5 is the size criteria. If the lesion is up to 15 millimeter, it is less than 15 millimeter or 1.5 centimeter, it is categorized as a category 4 lesion. And if the size is equal or greater than 1.5 centimeter, then the lesion is characterized as pyrette category 5 lesion. And we can like this is the diagrammatic representation of an extracapsular lesion, which is seen on the MR image as well. You can see that this is breaching the capsule here and extending outside the capsule. This is an example of category 3 lesion, which is faintly seen, and an example of category 4 lesion, which is very clearly seen as hypo-intense here, is showing diffusion restriction. So like I have already described, category X, in which we cannot comment because of some technical issue with the study. Category 1 is I have a very low suspicion of having clinically significant tumor, while category 5 have the highest suspicion. This is, I will show you a few examples. You can see that this is the axial section of the prostate. You can nicely see the peripheral zone and changes of benign prostatic hyperplasia in a very well encapsulated transitional zone. There are certain areas of low signal intensities which are appearing bright on diffusion and low on ADC. But if we see on contrast, the enhancement is not very marked, and it is only patchy or popcorn type of enhancement, which is commonly seen in benign prostatic hyperplasia. This is an example. You can see that the white signal of the peripheral zone is lost on this side, which is faintly seen on the functional sequences, and there is faint enhancement. This kind of finding we see in cases when we have focal prostatitis kind of picture. But if you see something which is very clear like this, very focal, showing you abnormal signal intensity on the functional sequences in diffusion and ADC, appearing bright and low, and showing enhancement on post-contrast sequences, this is definitely a category 5 lesion because this is greater than 15 millimeter. And on the sagittal section, we can see that this lesion is extending beyond the capsule of the prostate gland and is approaching the level of seminal vesicles. This is the seminal vesicles on the coronal section. This is another example of a lesion which is seen in the anterior part of the prostate involving the anterior fibromuscular stroma, showing you definite abnormality on the functional sequences on diffusion and ADC. And since this is very much clear, this also is labeled as a category 5 lesion because the size is greater than 15 millimeter. On the bottom images, we can see that another lesion here, which is the same lesion here taken in sagittal and coronal sections, showing you extension beyond the capsule of the prostate gland. So there are certain challenges and limitations for the MRI because MR is now being used as a triage test as it is considered as a cost-effective diagnostic approach for the detection of clinically significant prostate cancer. So there is further need for some improvement in the standardization of PIRATs. And the reporting has been made because this practice is mostly in the North America, and some European countries are using the PIRATs, and this system, of course, needs further testing to make it a more standardized tool. And this, of course, requires high dependency on the radiologist experience and training as well. So, and MDT, of course, they are definitely very crucial to discuss the radiologic and histopathological findings and making the decision for our patients. And future development now, there is ongoing research for biparametric versus multiparametric MR, in which the contrast aspect of the MR is not routinely used. And there is some advancement in the ultrasound, which is also called as multiparametric MR, but these are still to be established, and these are the two studies in which they have shared their experience with these two. So in conclusion, I will say that multiparametric MR is still rapidly evolving and a very useful tool for the diagnosis, localizing and staging of prostate cancer, which facilitates the targeted therapies, and it has the potential for reduction of unnecessary biopsies and provide a rapid and accurate diagnosis for both the native and recurrent tumors. Thank you.